Okay, everyone, welcome back. So we're going to dive into some of the case studies, and the first case study is on tuberculosis and the perpetuation of health policy double standards. And we're going to look at at latent TB, and we've divided this into three parts. I'm going to lay out some of the background of the case, kind of the medical part of it, and then we will have Christian McMillan talk about cost effectiveness and really talk about TB, bring in the example of water and the institutionalization of health economics. And then we'll have Tom Nicholson and Catherine Admey talk about the WHO and its responsibilities under global treaties and really how this all relates to our question of accountability. So I just, because I realize everybody in this room probably isn't up to date on the latest on tuberculosis. It actually doesn't change, so if you actually knew it from 10 years ago, you would be sort of up to date, but I'll just go through it anyway. About 10 million people get TB every year, and we actually only discover 6.1 million people using the methods available to us, and or the methods that are recommended. And so 4.3 million people are not identified. It's a big problem, obviously, because it's an airborne disease. It affects the poor, people who live in crowded living conditions. If they're not identified and treated, they spread it in their families and communities. Now, there's drug-resistant forms of the disease. There have been for many, many years. There are about 600,000 people who have strains resistant to the medicines that have been prescribed by the World Health Organization and other international bodies. Only 60,000 of them get treatment. About 1 million children get the disease every year. Only 1/3 of them are actually found and potentially treated. They're diagnosed and some of them are treated. So it should come as no surprise that even though we've had a cure for TB since 1948, about 2 million people die every year. Children, people with drug resistance, etc. HIV is actually the biggest killer of people with, TB is the biggest killer of people with HIV. So it works synergistically with HIV for various reasons. The TB bug upregulates certain receptors that make it easier for HIV to infect cells. HIV blocks the function of certain cells that make it easier to get TB, and so they work very synergistically with each other. So this is the biggest killer of people with HIV. Now, you'd imagine that if we've had a cure since 1948, rates of TB would be dropping quite rapidly globally. This is the global rates of TB. It's roughly about 120 per 100,000 right now. The rate in the US is about 2.9 per 100,000. So globally, it's about 120 per 100,000, and it declines 1.5% per year. So it's obviously a very glacial decline. And as I told you, it kills a lot of people with HIV still. So if you start to look at the US rate, which is roughly 3 per 100,000, and you look at the global rate, which is 120 per 100,000, and you map it out that we're going down at 1.5% per year, if we continue at the current pace, it'll take 200 years for the global rate to reach the US rate. So obviously that's not a good thing. So why haven't we been able to stop this epidemic globally? So the answer to this is quite complex. And Christian McMillan will go a little bit into this, but let me just give you some background on the disease and then just kind of build up to answer that question. So this is a bacterial disease the bug for which was identified by Robert Koch in 1882. So it's not like we don't know exactly what causes it, and people have known even before then that close, prolonged exposure to untreated people, etc., can cause the disease. And the first drug to combat tuberculosis. So between Koch's discovery of it, and of course TB's been around for arguably thousands of years before then, people were, after Koch, people were put in sanatoria and other things to separate them, even before Koch, actually, in the 19th century. But in the 20th century, you get this amazing discovery. In 1943, streptomycin is isolated from soil in the laboratory of Salmaan Waxman at Rutgers University, and he sends it to colleagues at, I believe, Merck, and they purify it, and it's put into a patient, and it's shown that it can cure them. So really, as early as 1944, you know that it can be cured, and they noticed that if you the first clinical trial actually is done by the British Medical Research Council on streptomycin. I think they give it to about 100 people, and they get cured. Most of them get cured, but a number of them relapse. So they realize that if you use one drug, you get drug resistance. And it really opens up, this TB is the disease where you have so much of our current medical approaches, our approaches begin from the way we've looked and viewed TB, from clinical trials to a lot of drug discovery. So, this is the problem that has plagued, humankind to at least throughout the 19th and 20th centuries in large numbers that have been quantified. And early 20th century. You have it being linked to a lot of movements, nationalist movements. The Bolsheviks wanted to get rid of it. Ataturk wanted to get rid of it. You've got movements in almost every country, from Denmark to Canada, these anti-TB associations. It's a big part of the nation state. It's a big part of modernity. So no surprise, after streptomycin, you have the identification and creation of a number of other drugs that are anti-TB drugs. So really by the end of the 1940s, people know that you get drug resistance. People know that you can use a combination therapy, and some very important observations arise that help us stop TB. So, as far as drug resistance, streptomycin causes it. You give it with another drug, para-aminosalicylic acid, you don't get it. Isoniazid is invented. They try to give it alone. Isoniazid is used for TB. It was invented earlier. They try to give it with. They try to give it alone. It cures people. You see drug resistance. They give it with streptomycin and para-aminosalicylic acid. You don't see it. You see very high cure rates. So everyone figures out you have to give multiple drugs to people. People figure out that very early on, the British Medical Research Council does a survey in England looking at drug resistance. Interestingly, I think it's around 1955, and they find that there's drug resistance to these new drugs that have just been invented. So, and the suggestion is primary drug resistance. So they go to people who have never been treated, and they take their strains and they find drug resistance. So they realize that drug resistant strains can pass from person to person, and you see this in the United States. So the idea is that you really want drug resistance is a bad thing. It's really going to be passed on. There's a number of studies on it in the 50s and 60s looking at, what happens if you treat somebody or if you don't treat them? Do you stop transmission? And of course, if you treat somebody, if they're untreated, you get 100% transmission to guinea pigs, who are in a little chamber above where the patient is. And if you actually treat them, you get almost 0% transmission to the guinea pig chamber. So there's a lot of scientific studies that are supporting that you have to get people on treatment really quickly so that you don't have transmission of the disease. And then people have noticed that if you treat people and you screen their relatives using x-rays, which were of course invented in 1895, if you screen them and you give x-rays, you notice that maybe 6 months later or a year later, some of their family members get it, even though you've treated the index case. So they realized that there was some sort of something they were calling latent TB that existed, and the United States Public Health Service in the 1950s goes into Alaska, and they create a treatment program in hospitals and then in the community, and they notice that people's families are still getting infected, and they do a study. They say, what if we gave these people who we think have this dormant form of the disease isoniazid, the single drug, will they get better? And they find out that, will they get the disease? And they find out that they don't. And they not only find out that, but they find out that rates of TB, which are very, very high, drop rapidly. These are not rates of TB on this graphic. This is a graphic of infection inside households, which is a proxy for transmission. But they show that transmission, if you treat the disease and you give this dormant form treatment, you get this massive drop. So there's a lot of principles that emerge really, really quickly, and these principles are put into practice in Western countries immediately. Search for newly infected people. Get people on therapy quickly, give them the most effective therapy so that they become non-infectious, help them take the medicines because you have to take it for a long time. In those days, it was 18 months, and treat all the contacts that have the disease with this kind of prophylaxis so that they don't get sick. This stuff is known. So by 1962, this is the norm. This is the standard of care in Western countries. And and then a couple of things happen. And I think, I really appreciate the conversation that happened yesterday, because I think the couple of things that happen are really at the intersection of, as we discussed yesterday, colonialism and and neoliberalism. And you have, and Christian will talk more about this, I think, or maybe not in this specific talk, but he's written about this, that, as early as the 1950s, when we've known that isoniazid monotherapy is a problem, the British are recommending isoniazid monotherapy for the colonies. And, I mean, I hope I'm not stealing any of your thunder, but in your book you put it so beautifully that even the British doctors in Kenya are just horrified that there would be this suggestion, because it just doesn't make scientific sense, and it's going to lead to more resistance. And then neoliberalism comes in, and I want to talk about that in a little bit more. So both speakers yesterday brought up the fact of selective primary health care. So you have this feeling in the 1950s and 60s, there is talk about cost, and even the debates about whether to give people full care or not, or use isoniazid monotherapy, are around the fact that, well, it's better to just give one drug than nothing. And essentially that, these guys can't afford more than the one drug, so, let's just do that. You get the call for Health for All in 1978, and by 1979, you have Kenneth Warren, who's the head of the Rockefeller Foundation, convening people, around that period, talking about convening people at Bellagio to talk about, can you actually do primary health care? Is it, given the financial circumstances in the world and other things? And they come out with this paper, which we saw yesterday, I think Randy showed it to us, on, selective primary health care, an interim strategy for disease control in developing countries. And for TB, this paper is monumental, because really in their plan they rate some priorities, right? High priorities like diarrhea, measles, etc. And you heard yesterday that Jim Grant from UNICEF was brought on board to support this, because there were a lot of things that you could give shots and other things for, and it really fit well with these single interventions that you could do. But for tuberculosis, they recommended not treating it, because they said that it was kind of like a it was a medium priority, and they in fact said that you can best deal with this disease and sleeping sickness and Chagas and other things through more research, and really not to focus on it. And it led to this kind of relegation of TB to kind of a second tier, and funders weren't funding it. So you have again, I'm putting 50 years of history together, but you have a debate going on in the 1980s in the TB community. People are doing studies and showing how you can lower prices. Drugs like rifampicin, which are part of the backbone of treating it, go off patent. And Chris Murray, who you heard about yesterday, developed the disability adjusted life year instrument. He has been working, he turned out to be friends and working with Carl Stieblo, who was one of the colleagues that worked on TB control. Carl Stieblo had taken this whole package of giving these antibiotics that treat TB to community health workers in East Africa, and not involving doctors, and really creating the equivalent of a shot. You go to these people's houses, you give them their medicines, you go every day for 6 months, because it takes a long time to treat it, but that you can actually cure it, and it doesn't cost that much. So he's in dialogue with Chris Murray, and Chris Murray's working with the World Health Organization and the World Bank on the World Development Report for 1993, and basically treatment of TB enters this report as one of the most cost-effective interventions. And and then WHO, being part of this, jumps onto this and says, well, we are going to run with this. We now have this intervention that fits perfectly in the primary healthcare / selective primary healthcare paradigm, and they declare an emergency. They in 1993 they say there's 8 to 9 million cases of TB a year, and they actually say 1/3 of the world's population is infected with it. Right? The people that Comstock and these guys in Alaska were treating, they say 1/3 of the people of the world are infected with this latent TB. And therefore, this is a global emergency, and we're going to create a thing called DOTS, Direct Observed Therapy Short Course. Those were the 4 drugs that you have to take for 6 months. It's not really that short, but shorter than what it was. So Direct Observed Therapy Short Course. And so they create this campaign, and they're under a lot of pressure from the World Bank and other people to make this very cost effective. And so they create this as a very simple program. They ask countries to have political commitment, diagnosis with sputum smear microscopy, standardized short-course chemotherapy, a regular supply of high-quality drugs, and then standardized recording and reporting so that they can follow along. So it's really simple, easy, low cost. It totally fits, more or less within the selective primary healthcare paradigm. A paradigm where you go in, you do an intervention, you're not investing in building health systems, you're not doing anything like that that would upset the financial apple cart. You're just, you're doing what you need to save some lives. Now, this, of course, is a very minimalist intervention. It doesn't, TB is airborne, I told you, and this doesn't focus at all on transmission or infection control. There's no, just to use today's lingo, there's no emphasis on health system strengthening. This is about creating a vertical program like what selective primary healthcare was talking about, really the equivalent of going and giving an injection. They immediately, even though drug resistance had been seen from the first time a drug was used, this system said, we're just going to give a package of first-line drugs and we're going to forget about drug resistance because it's really not that important. And it was kind of a one-size-fits-all. So some people have TB that's in their lungs, some have TB in other parts of their body. This wasn't going to focus on that. This also didn't focus on active case detection. They said, we're just going to wait for people who are sick to come to the doctor. And when they're sick enough, we're going to treat them. And they said, we're not going to go and deal with their families and stuff. If people want to, they can, but that's not going to be part of our program. They also took out this idea of latent TB. They said, we need to focus on the most infectious cases right now, and we're going to deal with latent TB another time, later on. So we're just going to focus on this for now. And then they also, they used a form of diagnosis, smear microscopy, which was developed by Koch in 1882, that did not work very well on people with HIV. So remember, this is 1993. The HIV epidemic is killing thousands and thousands and thousands of people all over Africa and in other parts of the world, but in Africa particularly with TB. And so this mechanism that they pushed was not able to diagnose people with HIV, not able to diagnose children, not able to diagnose people with TB that's not in your lungs, and of course not able to diagnose drug resistance. So a very, very minimalist approach. Now, and our group has spent a lot of time working on this, but this is just a very, we focused on drug-resistant TB, and here's a statement from the WHO in the mid-90s. It's a false statement, but MDR-TB is too expensive to treat in poor countries. It detracts attention and resources from treating drug-susceptible disease. And the same thing, they said if you focus on anything but smear microscopy, if you start using X-rays, if you start using cell culture to figure out if somebody's got drug resistance, if you start doing latent TB treatment, you're going to detract attention from what we need to focus on, which are these most active cases that show up at the doctor coughing blood. So they kept it really simple. So I now want to jump, because our case is on TB infection. I've given you a whirlwind history of the science behind TB, and I want to give you a whirlwind history behind the science of TB infection. So this the idea of latent TB, latency is a term that developed, but these bugs initially were thought to be dormant, then the term became latent, but it's really mycobacteria that are present in people, but they don't seem to have symptoms of disease. And these bugs can either go down a path where they sleep forever, as it were, or you get active disease. And 10% of people get active disease. So 1 in 10 people will get active disease. Now, Comstock was one of the first studies. They did this as a randomized controlled trial, the highest life form of knowledge, and they showed in households that if you actually treated. And they looked at children under 3 who can usually only get infections from people in their own households. And they showed that if you actually treated all the active cases and you gave this medicine, you would see this drop in transmission in households, and presumably the community would drop to 0. And they saw this in a matter of 5 years. So you needed to have a good treatment program, a good treatment program for TB infection, and you see these massive, massive drops. Remember, the rates in Alaska were 2,000 per 100,000 when Comstock started, and then they dropped markedly. And this is it over the years. These are the household infection rates. And you can see that they really, really drop rapidly, more rapidly than ever seen. And so they do this study in Bethel in Alaska, and interestingly, they even quantify that of the drop that they saw, 68% of it was linked, of the risk reduction, was linked to the reactivation of TB from this so-called latent. So the benefit of this program of treating the latent disease was technically greater than active disease. So you had to treat active in order to be able to successfully treat the latent, so-called latent disease, but it actually gave more of a bang, when you put them together. They also, people were like, wow, this is crazy. This is, such an important finding. Comstock and his team followed the patients for 20 years. So they also found that, as they followed people, they saw that this reduction was enduring. And here's a quote. They said, "We can no longer be serious. There can no longer be serious doubt that the daily administration of isoniazid is effective in preventing tuberculosis under a wide variety of conditions." Then 20 years later, they said it is probable that the effectiveness of isoniazid has been underestimated in this study because its effect went out for 20 years in a community that was still poor and had previously had such high rates of TB. And then this whole idea, Comstock really said these are the seedbeds of disease, and although we can't identify who's going to be at risk, if we were to really concentrate efforts on stopping this seedbed, that's how we're going to stop the disease. And Western doctors, Western countries, anybody here who's gone to med school knows that this is what we learn in med school. This is what people did to actually stop the disease. So after Comstock, there were a number of studies. So it's not like Comstock did this study and nobody studied it again. Over time, in non-HIV infected patients, there have been 11 randomized controlled trials that have shown that this works, and you get a similar reduction in risk, attributable reduction in risk. And subsequent to that, in the 1990s, there were a number of studies of HIV-infected people, because remember, this was the biggest killer of people with HIV, so if you could prevent people from getting infection, you could prevent death. There were 12 placebo-controlled trials that showed that this worked in people with HIV. So absolutely no doubt, beyond a shadow of a doubt, that this was the right approach to do. Now, here's the US guidelines from July 1999. It says infected persons who are considered to be at high risk for developing active TB should be offered treatment of latent TB infection irrespective of age. And can I tell you that the Preventive Service Task Force in the United States, which for various reasons really only looks at data and not cost, has listed this as a priority intervention. So it's a really, it's really, it's standard of care. How much prevention is needed? Comstock even showed, so these guys were amazing, for their day. They mapped out how much people could take and how much, if you took just a little bit, how much reduction you got, where the inflection point was. So they said, if you take any, you get a benefit. If you take 6 months, 6 to 9 months, that's where you get a lot of benefit. Over time, there were different regimens. Comstock used isoniazid. Some people started using rifampicin daily for 3 to 4 months, and it worked. Some people used rifampicin and isoniazid, and it worked. There's a new drug, rifapentine, more recently, and that's worked. So, the idea that, there were even a variety of regimens. It was enduring and durable, as I told you. There was some side effects. People could get hepatotoxicity. So there was a big study in Eastern Europe done. Should you do this to people? What if they get liver problems? Well, it turns out that they took some guys who had had TB and were at high risk of getting it again, and they did a placebo trial, unbelievably, and they put some into a group that got isoniazid and some they just followed. And the guys that took that didn't get the drug had lower rates of hepatitis than the people that did, but they had this really high rate of getting TB, which increased their risk of death. So over time, there was just, every variation of this. People said, well, if you give this drug, you're going to get so much drug resistance. And I think there's what is it, 13 studies that have studied, do you get drug resistance from giving this to populations? And the answer is no. So over time, every single variation and question and thing that you could say about this, that it's not going to work, it's bad, it's going to cause drug resistance, it's going to hurt people, have been studied and studied and studied and shown that it's going to work. New York City had an outbreak of drug resistance and of drug-resistant TB. It had a huge outbreak of TB in the late 1980s. The rates in Harlem were over 150 per 100,000, so similar to parts of India and other places. So what did New York do? They did, I think, very similar to what Comstock did, but they also dealt with drug resistance. They did active case finding, treatment of all forms of TB, treatment of patient supports, and treatment of so-called latent TB, TB infection for context. And what happened in New York? Huge drop in the TB rate, okay? So clearly, I don't need to tell this crowd that I showed you that the WHO graph that, the rate dropping 1.5% per year after DOTS. This is what's possible. That's what's happening. And in fact, the WHO, colleagues in the WHO themselves have modeled this. They have shown that if you just treat people, you get this. If you treat active and latent disease, you get this. So these are not, these are secret, a secret that's unknown to people. It's unknown, it's been modeled, it's been shown repeatedly. Okay, so why has this not happened? And I'm gonna let Christian go more into it, but just to give you a taste, in 1964, the WHO brought together an expert committee that said it's not feasible for poor countries. Nothing about the science. Remember, Comstock's science was impeccable. 1974, more science, more follow-up, not feasible for poor countries. They just can't do it. 1982, not feasible for poor countries. Shouldn't even be on the agenda. 1993, not part of the DOT strategy. 2015, Tom and I were working on trying to fix some of these things. We were in Geneva and somebody said, "Oh, have you seen their latest, their website?" And we were horrified because on their website, it actually says if your country is lower middle income or if your TB rate is over 100, don't do it. We don't recommend doing it. Comstock did it when the rate was 2,000. And he's not the only one, but these guys don't recommend doing it if your rate is greater than 100 or if you're poor.
How many high-income countries have a rate of TB over 100?
Right, so not a lot of high-income countries have a rate over 100, and interestingly, China and Russia have just gone below 100. So, this number was very calibrated to have the least amount. So Tom's going to go a little bit more into that, but that is basically the rapid-fire story of TB that forms the basis of this case.